Okay.
Okay, already.
Hmm?
Shall we start?
Yeah, we can start, I think.
Assalamualaikum. Mute your
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Thank you very much for reallocating time to attend our second session today. This morning, we will have a topic related to the hospital, so very specific. Yesterday, we already got some knowledge about the global health system, and today we will have some topics related to the hospital. Um, Dr. Wyatt, today it's supposed to be Miss Arifa as the moderator, but yesterday she's already on duty, so today I will do my duty as a moderator. Thank you very much for attend this the second session. I remember Dr. Maya is the first person that I met when I arrived in Leeds. At the time, I didn't attend the student orientation the first 2 weeks because of visa application issues. And he's the one that I met when I arrived after did my final examination in Master of Hospital Management here, and a day after, and then traveling to Leeds and meet to Dr. Maya to catch up the modules. Yeah. So today, Dr. Maya will deliver the topics. It's about rethinking the role of hospital, integrating a public health perspective. So it's very interesting because we can see the perspective from public health from the hospital as a provider. So time, I give please to Dr. Maya Omar.
Assalamu alaikum. Today we have a small class, so I suggest let us be more interactive and don't wait until the end to ask questions. So if you want to ask clarification, please raise your hand and we can clarify. And if you want to add something on the discussion, please add. If you don't understand some of the things I am saying, please ask, I will clarify. So today, I want to share with you a new perspective, rethinking, because the way we see hospitals and the way we want the hospitals to be are two different perspectives. So that is why we are saying to let us rethink the new roles of the hospital now that we are in the 21st century. The hospital, what they were doing before, which is so many things, and you will tell me what the hospitals do, and then to get away from this culture of thinking the hospitals to do A, B, C, D, but to do additional things on the top of what they are doing. So one of the, sorry, what I want to start talking about is the what I want to talk about, first of all, are the challenges for hospitals. You all are studying hospital management. And in your studies, you need to think of the difficulties that your hospital management is. What are the things that we are really concerned about? And the things that are big challenges, one of them, so one of the, what I want to start talking about is the challenges that we are all day, every month, every year are dealing with is money. Hospitals are not having enough money to run and to provide the services that the communities are expecting them to provide. This is not only in Indonesia, but also is true in the UK, is true in America, is true in Russia, is true in everywhere. Even in UK, I presented yesterday that beautiful example. The money is always a problem. These days, there are a lot of demonstrations, strikes by nurses, strike by ambulance workers, because they are not happy with the salary they are getting. There are always problems about money, money, money. The other challenge that we face in running hospital is the population that the hospitals are serving are demanding, always demanding for better and more and more and more. For example, you might not remember your grandfathers and my grandfather, when they had problems with their eyesight, cataract, they will go to the hospital, they get the cataract removed, and they will be lying flat on bed for 7 days and not allowed to move, just like this for 7 days. Then when they get up and the doctor prescribe them new lenses, and those lenses used to be very big and thin, if you remember, very big lenses, very bad looking. But when we used to give to the patient who was not able to see before, and you say, can you see how many are these? 2, 3, 4. This patient used to be very happy. Doctor, now I can see everything. And be very thankful to the doctor who did this operation. He was not worried about the ugly looking lenses on his face. Today, people don't want it. They want beautiful lens that adds to their beauty. They want the frame to be nice and thin and manageable. You know, it just does it by itself. So, and this is true with the demand of every other services by the people. People are demanding for better services, and this is a challenge. It is a challenge, especially when the money we have to run the hospital are not enough. The other big challenges the hospital face is the disease pattern that these hospitals used to treat in the past. There are new diseases, difficult diseases, long-term illnesses that you don't recover, but you just try to make the patients, people to live normal as possible. So in the past, we used to admit patients for diarrhea, for malaria, for respiratory, for coughs, for appendicitis. These days, the diseases that patients are presenting are changing. Another important change, another important challenge is also the future roles of the hospital. Do we want the hospitals to keep doing what they have been doing 50 years, 60 years, 100 years ago? Or are we looking for a different role for the hospital? So just think of this as students of hospital management, as real challenges, real problems that you will always be facing when you run a hospital, a health center, a health facility, a department of the hospital. Is that clear so far? Let us take one by one all these challenges. Let us start with the finances, the money. Why the money is not enough? A lot of things. Some of them are to do with the global economic situation, the economic downturn globally. Now, for example, the war in Ukraine, between Ukraine and Russia. Imagine the amount of money that is spent on this war. The food that used to be available from Ukraine, grain, oil, all this gas, petroleum, all these have stopped. They affect the economic situation. A few years ago, we are still struggling with COVID-19. The COVID-19 made it important for all the resources for each country to be diverted to deal with COVID. So the economic downturn at global level is one of the reasons why finances remain to be up. Second issue related to financing is the impact health and social services are consuming. When I was working in the health system, it was very simple to diagnose a patient. A patient comes, you spend time, you listen. We used to be told that vital signs, check the vital signs, the heart rate, the temperature, the respiration, blood pressure. And with those checkings and listening to the patient history, palpating the body, we were able to make the diagnosis. It didn't cost anything. Just the skills of the doctor who is, nurses were doing the same. But now we need MRI, CT scan, laboratories, different equipment and technology. They are all adding and adding and adding cost of running. also, the budgets that the government gives to the hospital is decreasing because government has to cover many things. Schools, not only hospitals, schools, repairing roads, building new roads, yeah, building those 99 tomb mosques, all these things. And, and as the result of that, it is reducing the budget that, that used to be given to the hospital. Um, the hospital costs, I said, is going up, the budget is coming down. And then another related to finance is we want to make maximum use of the little money that we have. We know we are not going to get more money. We know the demand is increasing. We know the diseases are changing. We know that the costs are going high, but the money is less. So what we call the efficient use of the money, economic efficiency, trying to achieve as much as possible with the little that we have, is the challenge you will all be facing as future managers of hospitals. You cannot say, oh, we don't have money, we don't have this. You have to do a lot of things with the little that you have got. Affordability of health and hospital care. Hospitals are not affordable, care is not affordable, but again, it's to do with the less money. The health financing systems. Yesterday, I explained two different financing systems of hospitals. The UK, which is financed through taxation, the UK, which is financed through insurance, but there are also other ways of financing hospitals. For example, the user charge, what we talked about. Patients have to pay money to receive the services, to be seen by a doctor, to have the tests done. So these are ways of financing the health system that are also becoming major problems. Social health schemes, universal health coverage. Universal health coverage, for example, is saying, yes, we know it is costly to run a hospital to treat people, but we want to protect the society from catastrophic payment. From the countries that I have worked, I know, for example, that if a child is sick, the parents of that child will sell the animals, will sell the land in order to pay for the treatment of that sick child. And that is causing economic catastrophe to the family's income and future resources. So the issue is universal health coverage is that we have to protect the people from that overspending in order to get treatment. But we have no money, have little money. And then the issue about availability of hospitals and the issue about equity. Those people who are in more need to make sure they get the hospital. So these are challenges in regard to financing or finances of the hospital. It's something you have to learn how to deal with all of these things. Maybe some of you will say, we don't want to have hospital money. I also mentioned another challenge is the demand of services are increasing. New illnesses, for example, unceasing demand of hospital services. It's not stopping. People get ill every day, every minute. Accidents are happening. Emergencies are happening. We're having record numbers of patients. We are expecting to deliver high quality care with little resources. We are trying to meet the expectations of the patients so that they have good experience when they are coming to the hospital. When they leave, we want, like that old woman, old man, with big spectacles to say, thank you, doctor, I am really happy to see. We want now, when the leave the hospital or get treated, they should be feeling that, thank you, doctor, thank you, nurse, thank you, hospital. The expectations and their experience is as positive. Another demand is mentioned about the demographic changes. Fortunately, our forefathers used to live 40 years, and when they are 50s, they used to be old man, old. Now, at the age of 70, we are still, yeah, we still want to pull out skin, we want to look good, we don't want to be old. And also, people are living longer than. So, because of those demographic changes, reduction of birth, because of the birth control, is leading to have a population that is aging. So when child mortality is reduced, when people don't die when they are young, then they live longer. And this old age itself is a challenge, because when we get old, we definitely have a lot of health problems. Age itself is a condition which is not as enjoyable as it's not a healthy experience. Once people hit the old age, their blood pressure will be high, their oxygen levels will be low, their hearts start to beat slowly, they will have problems with the infections, they might be they will have diabetes, all these issues because of the aging population. The aging population will come with new health problems. There are what we call the increased patient acuity because of the comorbidity. Comorbidity is when somebody, and this is what happens, a lot of people now have got more than one disease. In the past, you have our older generations, they used to have just one disease. Pneumonia, to treat the pneumonia every season. Now you have got comorbidity, pneumonia associated with heart problem associated with high blood pressure associated with high cholesterol levels, associated with diabetes leading to kidney failures. So people have more than one disease, and that is making the health issues more complex. It's not just if you treat one, it is sometimes the medication itself for treating one disease is resulting to another disease as a side effect. So the health issues are becoming more complex. And also, when patients are admitted to hospitals because age, because complex illnesses, because a number of illnesses they have, they tend to stay in the hospital. And if you are not able to discharge the hospitals as quickly as possible, what will happen? What will happen if you don't discharge patients very quickly? You want to discharge patients or you want to keep them? Anybody knows what will happen? No one knows? Okay, I will tell you. If patients are not discharged as quickly as possible, then there will be no beds available for new patients to come with acute conditions. For example, in UK now, one of the problems because of the length of stay, when an ambulance brings a critically ill patient, the hospital is not able to receive that patient as quickly as needed because there is no bed available. So the ambulance comes way too hand over the patient, 4 or 5 hours takes, the condition of this patient deteriorates and some because of the availability of bed in the ward. There is no bed. And this is what I want you to think later on. We need to change this. The role of the hospital not to keep patients for a long time, even at least chronic patients, so that we discharge patients as quickly as possible, as soon as they stabilize, and then the care can continue in the community, so that they go home. There will be nurses going and providing treatment. If rehabilitation is provided, it is given at the community level, so that the hospital stay is reduced as much as possible. I said another challenge is the demography is changing. We tend to be having more older population than before. And these older population are developing non-communicable diseases. So those diseases of the past, which used to be transmitted from one patient to the other, from infectious diseases, is not a big problem. It is the non-communicable diseases which we are developing as we are aging. Just like a factory, a car, an aeroplane, our systems of the body have. But this heart which we have here, it is pumping every second, non-stop. From the time we are conceived until the time we live. 10, 100 years, 50 years, gets tired. The muscles get weak. The liver that was doing all the job it was doing will be getting tired. The kidneys will be getting tired. The lungs will be getting tired. Our joints, our hips, we are not able to walk now anymore. We are not. When I went to the mosque the other day, many people were sitting on chairs. But I remember the old beautiful days. Even old people never sit on a chair in the mosque. They were still bending to before. Now people cannot because of the problem of aging. The bones, cartilage, all of them are getting. So these non-communicable diseases are also on increase because of the demographic changes. I want to mention these non-communicable diseases because we don't want hospitals to be continuing to treat these non-communicable diseases. They are, once somebody gets a non-communicable disease, it doesn't recover. Once we are diagnosed to have diabetes, type 2 diabetes, we live with it. It's never cured. Blood pressure never gets cured. Cancers never get cured. Kidney diseases, they never get cured. So these are conditions that people have to live with, and they don't have to be in hospital. So these non-communicable diseases are, in a sense, they are chronic diseases. Chronic, that means they last forever, or they go on and on. They only get worse rather than getting better. Another important thing to remember about non-communicable diseases is they are not passed from one person to the other. They are not infectious. They are not transmitted. If you marry a husband who has diabetes, he is not going to infect you with his diabetes. And the other way around. So these diseases are not passed from one person. Maybe genetically, the kids that you are going to produce might be susceptible and prone to develop that non-communicable disease. Communicable diseases are of long duration and they progress slowly. every now and then, as I said, they only get worse. And what we are calling these non-communicable diseases, invisible epidemic. We have seen COVID-19, it was visible when the epidemic happened. It was affecting a lot of people. It was passing on very quickly. That's why we are wearing masks. Many people were dying. We know people who died. And that makes you to be able to see how serious non-communicable diseases is invisible. And it is becoming, and they are becoming epidemic. There are societies, countries that are struggling to deal with diabetes and cancers and so on, because it's affecting a large number of them. For example, in the 2020s, it was estimated that 41 million people died of these non-communicable diseases. And these accounted for 71% of the overall deaths in the world. So when you combine all deaths, road traffic accidents, COVID-19, other diseases, you can name them. They did not kill as many people as non-communicable. People who died globally, 71% of them died globally. And the deaths, which are now at 41 million, is projected to be 52 million in 2020, and I think that is already hit that time. It is leading to high level of premature mortality. That means about 15 million people are dying before they reach the age of 70. Very worrying. I mean, 70 these days, somebody 70 years old is not considered to be old. Unlike past when someone is 50 years old, now even 70 years old are not considered old. In fact, you still see people getting married at the age of 70. And 85% of these premature deaths are occurring in our countries, low, middle income countries. So you can see, if as a hospital manager, the challenges that you have to face in the work that you are going to. And non-communicable diseases have now taken over other leading killers of the infectious diseases around. This is very interesting map, just showing you the colors, you know. By 2030, the global standards of the standardization of the non-communicable diseases. You can see on the left-hand side, it is the age estimates of the non-communicable disease mortality. On the right-hand side is the mortality of the non-communicable diseases, or the total number of deaths globally. Just to remind ourselves, I know you all know these, but just to remind you, there are 4 main types of non-communicable diseases. Cardiovascular, usually either stroke or heart attack. Cancer, respiratory diseases such as chronic obstructive pulmonary disease, asthma, and diabetes. These 4 diseases, you can see they are accounting about 85% of the mortality rates around the world. I have shown you this, yesterday, is the changing pattern of the causes of deaths from 1920 to 25. You can see how some of the diseases which used to be lower in the 20s are now coming at the higher rank. And these, for example, are the liver problems, problems with diabetes, Alzheimer diseases. Uh, what is the interesting thing in this picture you can see? What is the unusual that you can see? Can you read and tell me what do you see to be unusual? Anything? Can you tell me what is unusual here? Attracts your eyes. No? Are they all unusual? Happy? Fine? Uh, just look at it. Look to the different colors. Look to the diseases, how they shifted. And something, I see something very unusual. But I want you to pick. Okay. I think we can all go and have our eyes. What I see here, and when I look to the 20 causes of death, 2000, and then I look to the causes of death in 2025, just within a period of 5 years, I am seeing here three causes of death, which were not. Can you see any of those things that were not present in 2020, but they start to appear? Huh? What is it? Alzheimer disease. Exactly. Alzheimer maybe was very low. I'm not saying it was not there, but it was very low. But now it is number 7. It has come here. It was not there in 2020, but in 2025, it is the 7th cause of death. And Alzheimer is due to age. When we get age, then start to forget names. I start to forget. You then gets worse. You don't know. You don't remember yourself. You don't remember to eat. The other disease which was not there is the hypertensive heart disease, which is number 15 in 2025, and also colon and rectal cancer, which was not in 2020 as a major cause of death, but here it is appearing to be number 18, 18th cause of death. So that is really worrying. All these conditions that you are seeing appearing here, people get to be admitted to the hospital for them. They will stay long unless we try to rethink what hospitals are going. Just keep that in mind. This is fascinating data that from UNICEF. For example, the burden of diseases that are attributed to the 15 leading risk factors. You can see, for example, top cardio and cardio and circulatory diseases. But the dark blue there is actually contributed or caused or died dietary risk population. So the diet we are eating is contributing to high level of the same thing with high blood pressure, also contributed by sorry, household pollution, which means poor ventilation, way we cook our food, smoke, are also contribute to cardiovascular and so on. After the different conditions and contributing factors. If we are to deal with these conditions, we need to think of addressing those factors. Something about the diet we eat, we something smoking, we need to do about high blood sugar levels in our blood, we exercise more, we need to reduce the level of cholesterol in the blood. Is that okay? Is that clear? And these are the main causes of death in terms of percentages in Indonesia from 1990 to 2005. See data from 2010 after. I couldn't get information. For example, when you look at this table, you will see the causes of death either from the 1990, for example, communicable diseases of 39, in 2010, it has come down to 7. Whereas non-communicable diseases, the 4 conditions that I, which was 35.9% in 1990, 55.6%. So you can look at this table and see, even how these shift from communicable disease to so okay. Um, I find, for example, the last one, road injury, road traffic accidents, uh, which was 3.3 in 1990, then it went to 4.3 in 95, then it went to 4.5 in 2000, then it came down in 2005, and then it's starting to go up in 2010 and onward. Why do you think this is happening? Too many cars, too many, those ones I have seen last night carrying passengers in the front, yeah, without seat belt, yeah. You can imagine the moment that guy holds a brake, all those people will fall in the front and maybe getting injured. Something that you have to do to take action about or to influence the municipality to come up with an action. And I don't know what action, but it is worth to think about. In the past, non-communicable diseases were linked to wealthier groups. These used to be called the diseases of the rich. Diabetes was only affecting the rich people. because of their traditional lifestyles, they have cars, they were sleeping more, they were eating sweets and a lot of nice food, which the ordinary people did not have. But now it is becoming the disease of the poor. Why, why a disease which used to be of the rich people is now affecting the poor? Why do you think is the cause? Food, what type of food? Junk food. You can use your speaker, yeah.
uh, yeah, could cause some disease, and especially in eastern Indonesia, like South Sulawesi, because serving food to relation is a kind of how to make a relationship with people, and the food is not healthy food,
Yeah.
as you see. And yeah, this is the cause of non-communicable disease in South Sulawesi is increased because
Okay.
the lifestyle.
Okay. In many countries, these junk food, we call it, fast food, yeah, it is usually attracting the poor because, for example, Nurmala, when she was in Leeds, you go to the supermarket, you buy your chicken, you buy okay, good. So when you look at this figure, what you see, the contributing factors of non-communicable diseases, they are all modifiable. This is the good news. If something is done, we can modify all of them. We can modify our diet, we can modify smoking, we can reduce the air, the pollution in the houses, we can reduce the level of our glucose in the blood by eating less sugar or by exercising more. We can reduce our body index, the weight, and so on and so forth. So, with all those frightening figures I presented, I want to give you the good news, hope, which you as hospital managers can pass this hope to the people. For example, we can modify, and this is what I call modifiable behavioral risks. If people can modify this, the trend of non-communicable diseases is likely to fall. For example, tobacco, physical inactivity, unhealthy diet, harmful use of alcohol, all of these which contribute to the raising of the non-communicable diseases can be modified. Someone yesterday mentioned, how can we make people stop smoking? I had a friend who was smoking 2 packs of cigarettes every day. And after long discussion with his friend, I said, let us try to come up with an action. And I said, don't stop your cigarettes every day. But what I want you to do is reduce one every day. So when he was smoking 40 cigarettes a day, I said, tomorrow you smoke 19. Then after tomorrow you go to 18 or to and believe me, this chap in 3 months, he came to me, he said, Maya, this is my last cigarette today. So he came to 1. And he said, this is the last one. And he managed to smoke. So there are ways that if there is an awareness in people and the willingness, these behaviors can be modified. Just smoking itself, we know it causes 8 million deaths every year, including to people who are second-hand smokers, people who are not smoking. Just sitting with those people who are smoking also is making you indirectly smoke. So if your husbands, if your boys are smoking in the house, tell them not to, because you are also smoking with them. If you are going to restaurants, make sure these restaurants are not smoking restaurants, smoke-free places. And these things can be turned into rules and laws. No smoking in closed areas, no smoking in restaurants, no smoking in schools, no smoking in workplaces. Yeah. Another modifiable factors, for example, salt. Just reducing the amount of salt in our food can also reduce the risks of high blood pressure or of a lot of other diseases. Because more than half of the 3 million people who annually die due to alcohol use and non-communicable diseases and cancer, 830,000 deaths annually can be attributed to insufficient physical activity. Another modifiable factors are the ones that are related to the metabolic risk, which contribute to the, for example, raised blood pressure, overweight and obesity, hyperglycemia, and high levels of cholesterol in the blood. In terms of attributable deaths, again, the leading metabolic risk factor globally is elevated blood pressure. We can reduce these by reducing the blood pressure levels, sugar levels in the blood, and overweight. Non-communicable diseases, as you know, have severe socioeconomic impact. this agenda of 2030 for sustainable development goals is going to be threatened by non-communicable disease. So an action needs to be done. It is also found that from evidence that poverty is linked to the non-communicable diseases. And this is serious, especially in low middle income countries. It is eating a lot of household costs as well. We also found that in low resource settings, healthcare costs for non-communicable diseases are draining the household economics or resources. As I mentioned, people are spending a lot of money to get their relatives treated for cancer, diabetes, even paying for, the dialysis for 3 times a week. It is really costing a lot of money to all households. And it's a loss of income to the member of the family who is not well. And it is affecting the overall development of the country. Dr. Tedros Adhanom Ghebreyesus, who is the Director General of the WHO, is quoted to have said that there are cost-effective, globally applicable non-communicable disease interventions that every country, no matter its income level, can and should be using and benefiting from saving lives and saving money. When he was talking about the non-communicable diseases. Now, how are we going to address these challenges that I have presented to you? I want to bring you to the role of the hospital, which I want to change. So if we want to address this, we need to ask ourselves, is the current health system working? Is the traditional way of running health services by the hospital addressing or meeting the future demands that are as the result of the growing changes in epidemiology, demography, and the conditions that we have more mentioned earlier? So I want to remind you of this picture which I showed you yesterday. What we said yesterday, here, and I want us to put ourselves as hospitals into this big picture. Here you have a community in every country, a community that constitutes, and all these services have to happen within the community. Social services, primary health care and continuous comprehensive services, self-help group, liaison community health workers, and others. Just to give you an example, in every community, members of families are helping their individual members who are not feeling well. We care after our parents, we care after our kids, we care after our husbands and wives. And this is what we call the self-help group. We then also have got the social services who can come and help in dealing with or taking care of these people suffering from chronic illnesses. And then when people are discharged from hospitals, we have a system of primary care that provides continuous support or continuous care to these people. And then this community is surrounded by hospitals, which has got emergency department, where I gave an example, when there is a traffic accident, we rush to the emergency. Placenta, previa when somebody has complicated delivery. Although we want this to happen in the community, but if there is a complication, we run to a maternity services in the hospital. If there is a need to repair hernias or remove appendicitis, or we go to have a surgery in the hospital. We use hospitals as a training center. All the doctors, the nurses, they go to hospital for their training. Then we have got NGOs that are helping with people who have got alcohol or drug problems. The women, maybe not here, but in some countries, women who are affected by gender violence, they are supported by some of the NGOs. Then we have specialized preventive services, which we go to attend if we want to have a mammography done, cervical cancer screening, environmental lab to check the pollution, the levels. We also have diagnostic services that do CT scan, cytologies, and then we have got specialized care hospitals. For example, that deal TB clinics are specialist clinics, TB control centers, community mental health facilities, and so on. So this is like a nutshell of primary care embedding itself in the overall health system. Now, if you look at the hospital, just take the hospital bit. We say hospital does emergency care, it provides maternity care when in situations of complications, it does operations, and it is also a training center. Now, to address this challenge, we need to design hospitals to treat only episodes of acute illnesses. Acute illnesses means a woman who has got complicated delivery is a heart attack is an acute. Stroke is acute. We rush those people to the hospital. So we need to design hospitals to deal with those issues, operations, assisting deliveries, treating serious conditions as they arise in a brief period of time. And we know that these hospitals are not equipped or staffed or budgeted to manage long-term care. We cannot keep a patient for a long time. Once that acute case is over, just having someone stay there, you give food, you give injections, is not meant to do that job. And because doctors are mainly trained to diagnose, to treat, and to cure diseases, they are not trained to prevent diseases or to provide rehabilitation or long-term care. So in the hospitals, we have doctors who are trained by nature of their profession to diagnose when somebody comes with acute illness, to provide treatment, whether this is medical treatment or surgical treatment, and to cure that patient and send them home. If anything that is required after that, that is not what our doctors are trained to do. It is the occupational therapy, rehabilitation therapy, community nurse, and so on. And remember, hospitals are not people working in hospitals. They don't care about preventing of diseases. They are busy. In fact, they don't have time to talk about preventing of diseases. And we say it, if we want to prevent these non-communicable diseases, the 4 non-communicable diseases that we mentioned earlier, that are caused because of tobacco use, alcohol consumption, unhealthy diet, physical inactivity, and other risk factors, then that is not the hospital. So we need to transform the hospital. Okay? And this transformation has to lead to change in the way the hospitals are working. And this is a bit that concerns you as students of hospital management. This is a definition of transformation change from Business Dictionary. It says transformation of change is a shift in the business culture of an organization, which in this case is a hospital, that is resulting from a change in the underlying strategy and the processes that the hospital has in the past. And a transformational change is designed to be organization-wide and is enacted over a period of time. So it is not something you do once and finish with it. It has to continue for some time. And for example, traditional hospital focus, needs and treatment of individual patients is inadequate in itself. We need to think out of box, and we need to completely redesign the focus of hospital and the hospital care delivery. Focusing on patients and integrating the healthcare with other services that we mentioned earlier in that diagram, other services in the community and the surrounding areas. Now, what can hospitals do or transform itself to be part of the public health movement? I took this definition from the public health Faculty of Public Health in the UK, who defines public health as the science and art of promoting and protecting health and well-being. It is also a science of preventing ill health, and it also is a science of prolonging life through the organized efforts of the community. So, public health is about promoting, is about protecting,
place for suspension. So how we integrate it
is not what I would think. It's something that we can look at and think, but it is a useful model. That is why I wanted to talk about it yesterday.
I also remember.
Yes.
I also remember it's about the community nurse. I just remember my experience when I was in Japan. It's in the meso level actually, where I never contact primary healthcare. But when I was pregnant, I have to register to sub-district office, kantor camat. So sub-district office, I register I'm pregnant. So the government knows there is a pregnant woman in this location. And then after that, so they know they give me one person to responsible with this pregnant woman. So there is one people from sub-district office responsible for the pregnant woman. When I give birth, I also report I already give birth. 1 month after give birth, community nurse come with the schedule. So it's from primary healthcare. So this is integrated sub-district office and primary healthcare. I never contact, but they just directly come to the pregnant or a woman after give birth, and community nurse visit us as well to check our mental health especially. Yeah. Yes. Okay, I think for the first session, any last question? Okay, from Prof. Alimin, please.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Sorry again for coming late because I just came back to control my eyes from doctor specialist. My question, I just want to tell you about what I did when I was dean for cancers screening. We were have actually a cooperation with we have a cooperation with one of the college in Taiwan, with the community. We are copying their concept about the community screening for cancer, and then what we did here is gathering the community and then providing doctor specialists for IS, specialists for obgyn and GP, and that's all. We are gathering the community to check. They are actually, the main purpose is to check their cancer through obgyn. But to interest the people, we are calling GP to check their blood pressure, and specialist nutrition also as well, and also the other doctors. And I did for I think 3 times. My problem is the sustainability of this community program, and as well as the community nurse who do not have somebody to pay for. Probably you have any ideas how to support this kind of intervention, so that we can make a good intervention for non-communicable disease, especially cancer. Because in Makassar, one of the problems is we have a high percentage of cancer, especially for mama cancer. Thank you very much.
Thank you. I think that is where we started. When I started my talk, I started with the problems, including the problem that you are mentioning, which hospitals are facing at the moment. Running a hospital, one of the important challenges we said is finance, the money that is needed. And the money becoming a problem because of the things that you mentioned, the service, the type of care that hospital used to provide is changing. The hospital is treating more of the chronic conditions, non-communicable diseases, than 20 years ago. The expectations of the community, of the patients, are changing. They are demanding more when the money is less. So the problem you mentioned, they are real. And the talk we had today is to put all these in perspective, and my understanding is one of the reasons we train healthcare managers, hospital managers, is to have people who will be able to deal with those problems in order to make hospitals work better. If as human beings, if we expect everything to be available in order to do what needs to be done, we will do nothing, because everything will never be available. There will always be something missing. So myself, who has coming from health planning background, is always to think and plan and make decisions based on the little resources you have, and putting these resources in the right place and use them in the most efficient way. That will make difference to the care, the treatment, and the improvement that we want to do in the healthcare in general. So the government will never be rich to give everything. People will never have enough to pay for everything. And yesterday when I met the rector, he shared very fascinating example of a scientist, a researcher 200 years ago, who really did a lot to the understanding of the world today with very little. And I have a firm belief that we can really do something with the very little that we have, if there is that. But yes, and the approach I was talking about is these three levels: the micro level, which is the higher level, the middle level, which is the meso, and the micro, which is the lower level. And if the higher level is not supporting the middle level, and if the lower level is not supporting the middle level, then the middle level cannot work alone. There has to be an integrated approach of all the three levels to work together, so that the issue of community nurse visiting homes will not be a problem. There will be a way to, as I was talking to your colleague, sharing the UK example, where the functions are distributed and working is done very well in coordination, and everybody is doing his job. We even don't know who is paying for it. Thank you.
Okay, thank you, Dr. Maya. I think the last question from Prof. Alimin. We will have a short break, 15 minutes break before the session 2. We will still have session 2 with the topic hospital and their changing roles towards integrated people-centered health services. Thank you very much, Dr. Maya, for the first session. Yeah. We still have 15 minutes break. Assalamualaikum warahmatullahi wabarakatuh.
Saya mau bicara dulu begini, tolong diperhatikan terutama mahasiswa Mars. Ini kan bagus sekali konsepnya. Bagus sekali konsepnya. Dia ingin bagaimana definisi fungsi rumah sakit dan lebih banyak ke public health. Saya tahu ini kami dengan Prof. Alimin, dengan Prof. Dus Sampurna atau Prof. 20 tahun yang lalu ini kita sudah diskusikan bagaimana membangun kesehatan bangsa lewat promotif preventif. Tapi saya bilang ke beliau, tadi kan dia mengatakan kalau mau diimplementasikan ini konsep, ada 3 level pendekatan, baik level makro, meso, dan juga level mikro. Saya bilang ke beliau, ini agak sulit kalau kita mau implementasikan itu konsepmu. Tapi saya bilang ke beliau, kami akan bikin seminar besar untuk mengundang Kementerian Kesehatan dan juga BPJS, karena ini menyangkut bagaimana sistem financing. Nah, saya jelaskan bahwa kita punya BPJS itu sangat sentralistis. Satu untuk Indonesia, karena dia bilang tadi, kan saya diskusi kemarin, tapi dia bilang tadi, saya pikir kau kemarin bilang di Indonesia itu sistem pembangunan kesehatannya, sistem organisasi pelayanan kesehatannya ada desentralisasi, ada pusat, ada provinsi, ada kabupaten kota. Saya bilang iya, tapi sistem pembiayaannya itu tersentral oleh BPJS. Masalahnya sekarang adalah BPJS itu mau membayar kalau dia hospitalize, kalau dia masuk rumah sakit. Nah, itu salahnya. Nah, bukan public health. Public health kan ada 2 nih, UKP, UKM. UKP itu ya dibiayai oleh BPJS, tapi UKM dibiayai oleh pemerintah, mulai dari pemerintah kabupaten dan seterusnya. Nah, ini masalahnya walaupun dikunci di Undang-Undang Rumah Sakit, Undang-Undang Kesehatan bahwa di tingkat kabupaten, provinsi minimal 10% untuk kesehatan di luar gaji. Tetapi ini kan banyak sekali bupati dan gubernur yang membangkang. Dan kalaupun 10% itu bukan ke public health-nya, tetapi lebih banyak ke kuratifnya lagi. Nah, jadi mana ini Mars 5? Coba angkat tangan. Jadi tugasmu di Mars 5, kau dengar ya, kita bikin seminar nasional nanti untuk bagaimana fungsi rumah sakit. Saya diskusi tadi, dia bilang, oh kau bisa coba di tingkat kabupaten, kalau kau berhasil di tingkat provinsi dan kau bisa bicara karena ini perlu bantuan massal, kalau konsepmu itu kalau bagus. Jadi nanti kita seminar, topiknya ini, kita bisa juga undang dia bicara, tapi ya, kita sajalah jauh lagi kalau kita undang direktur BPJS kesehatan, mungkin di Pak Aco, Dokter Aco, kita undang. Ini bagaimana ini, terutama ini BPJS, konsep Menteri Kesehatan ini kan bagaimana membangun rumah sakit sebanyak-banyaknya, bagaimana menciptakan dokter spesialis sebanyak-banyaknya. Pasti pendekatan kuratif lagi kan. Nah, bagus sekali ini, saya betul-betul ini, bagus sekali konsep. Bahwa, nah maka lebih, tapi kalau perlu kita ketemu Prof. Aligup, minta kesediaannya. Ini ada konsep. Kalau saya temui itu dengan tampak kita, tolong Mars 5 perhatikan betul ini konsep, karena bagaimana mengimplementasikan ini. Yang pertama mungkin kita dekati adalah kita wali kota, karena tadi itu Dr. Bahri sudah jelaskan, sudah banyak diimplementasikan ini konsepnya toh, seperti itu perawat, dokter turun ke masyarakat pakai ambulans cadi, ambulans kecil. Nah, Ini yang saya pikir. Stop. Bagaimana mengimplementasikan itu? Jadi tolong nanti Adit, siapa lagi temannya Adit, Lili, mana Lili? Nah, itu nanti organize itu seminar supaya kita membuat satu seminar yang ya, mungkin tidak banyak pesertanya karena ini juga merugikan juga dokter kalau implementasinya ini lama, tetapi minimal bahwa kita sudah membuat konsepnya. Saya kira itu. Pikir dari tadi terus itu saya berpikir sambil saya berusaha menangkap karena ini bahasa Inggris saya sudah lama sekali itu. Jadi saya harus berpikir keras, cepat sekali, capek kalau saya mendengar. Jadi yang saya pikirkan tadi itu yang paling memungkinkan untuk mengimplementasikan itu adalah rumah sakit Unhas. Kenapa? Karena orang pintar semua di situ. Cuma tadi saya kasih tahu langsung, banyak masalah ini. Tapi kalau rumah sakit Unhas saja tidak bisa, pasti yang lain tidak bisa. Nah, itu yang saya uji coba itu di rumah sakit Unhas. Tugas Mini Arifah.
Tergantung Dewas. Kalau Dewas kasih fatwa langsung dikerja.
Rokok, terutama ini rokok. Tadi toh dia bilang setiap hari kok kurangi 1 batang. Akhirnya tinggal 1 batang. Nah itu banyak sekali yang bisa dilakukan. Nah pertanyaannya, bisakah kita ini dari Mars mempelopori ini konsep. Bahwa konsep rumah sakit yang mendekatkan ini dengan public health itu lahir dari sini. Kalau kita bisa bikin 1 kabupaten, karena contoh saya diskusi dengan dokter Indah bilang, susah Pak, tapi memang banyak susahnya. Contoh Prof, orang stroke sudah dirawat di rumah sakit. Sebenarnya ini kan dia pulang, kalau dia masih membutuhkan layanan kesehatan, sebenarnya itu kan tugasnya orang puskesmas untuk merawat, karena ini tidak butuh lagi pelayanan yang canggih. Nah, masalahnya tidak ada koordinasi dan komunikasi antara puskesmas dengan rumah sakit jika pasien itu kembali ke rumahnya. Nah, ini kalau bisa dijembatani oleh Kepala Dinas Kesehatan Provinsi atau Kabupaten, ini bisa jalan. Nah, semua itu bisa dijalankan. Jadi, dia lebih efektif dan efisien pelayanan kesehatannya. Nah, tadi ini Adit ini bertanya sama kau Adit. Karena saya pernah training di Inggris, tapi memang itu bagus sekali layanan kesehatannya dia. Karena saya dibawa sampai ke desa-desa, sampai ke rumah sakit yang paling canggih. Saya training di situ, memang bagus, lebih berkeadilan dibanding dengan Amerika.
Jadi ini memang rujuk kembali masalah besar. Selama 50 tahun saya jadi dokter, baru 2 kali dikasih kembali pasienku. Itu pun karena tabangku. Jadi bagaimana bisa rujuk kembali itu berjalan?
Kan ada memang programnya BPJS PRB kan, program rujuk balik. persoalannya puskesmas kalau terima rujuk balik hanya kasih obat kan?
Ya.
Hanya pasien hipertensi, DM rujuk balik kasih obat, tapi bukan perawatan.
TB.
Nah, yang masalah kan yang kayak butuh perawatan lama, stroke, cancer yang sebenarnya tidak butuh di rumah sakit. Hanya mungkin butuh pertahankan infus karena dia sisa apa sih namanya? Yang stadium akhir yang sudah tidak bisa makan. Tapi kan banyak pasien tidak mau pulang karena tidak ada keluarganya yang ngurus atau harus cari perawat lagi. Nah, ini barangkali harusnya puskesmas dong yang bisa menangani. Nah, ini yang jadi tantangan tadi sampai cari. Saya bilang kita bisa bikin pilot project barangkali satu kabupaten dulu.
Saya dulu usulkan ke Pak Sahrul Gubernur supaya bikin paradise place di mana tempatnya orang-orang tua di situ kumpul dan di situ berolahraga. Jadi ada pengobatan khususnya, tetapi dia salah tangkap. Dia bilang sudah ada mini bangun itu rumah jompo, padahal bukan rumah jompo, maksudnya paradise place. Saya bilang di mana kita kalau sudah tua 10-20 tahun kita kumpul ketemu di situ. Karena kita ini kan kalau selalu ketemu orang-orang tua itu kita kembali, tetapi salah tangkap. Ini susah ini memang public health. Karena bayangkan level gubernur saya tangkap. Padahal paling jagonya itu Pak Sahrul dari semua gubernur. Bukan tahu jurusannya. Sebenarnya kalau saya komitmen gubernur ya gubernur itu yang penting sudah komitmen, yang pelaksana itu ke kepala dinas. Ya bagus. Bagus. Tadi dia jago ya. Nah, konsep kita tadi yang Pak Cali bicarakan tadi itu mungkin dilibatkan gubernur supaya lebih cepat. Ya. 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 Betul. Cuma Pak Cali, kalau saya lihat kita di FKM yang follow up-nya yang tidak ada. Jadi makanya itu kenapa saya Hasanuddin tak bisa jalan dengan bagus karena ada orang yang di hire meskipun tidak mahal, tapi itu yang dia kerja terus. Nah persoalannya kita misalnya di bars, siapa yang mau kalau kita semua yang kan mau mengajar mau apa? Jadi mungkin ada orang, 1-2 orang yang alumni Mars di hire untuk menjadi administrator untuk bisa pull off itu. Ya, saya kira itu cocok. Dan apa namanya dikasih ya supaya bisa menangkap juga apa namanya funding dari internasional dikasih nama saja, beri nama. Tapi Mars. Jadi Pak Cali kita belajar dari Prof. Laksono lah. Jagonya itu Prof. Laksono membuat apa namanya bekerja kooperatif, kerja bersama.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. We entered second session of the guest lecture today. The second topic for the guest lectures is hospitals, their changing roles towards integrated people-centered health services. Okay, so Dr. Maya, please, time is yours.
Thank you. The voice is coming up from here. Thank you. So this session is building on what we have discussed. And it's the last one. What I want us to discuss together is, again, continuing on the changing roles. And this time we want to focus on how can we make hospitals to provide an integrated, patient-centered health services. Let's make this work. So what we are going to do in this session is discussing the nature and activities of the hospitals, as we started earlier. We will try to analyze the relationship of hospital and the health system. Then we will try to examine how the health reforms have influenced the hospitals. And then we will look to the changing roles of the hospitals around the world. It's a bit interesting to start off. What do we understand by a hospital? What is a hospital? Can anybody think of what is a hospital? Define, if you are asked to define what is a hospital, what will you say? When you say, I am a manager of X hospital, or I am the director of an X hospital, and then you are asked, but what is a hospital? What will you say? Yes?
Thank you. As mentioned in our regulation, that hospital is health services that provide from services from prevention, curative, and until rehabilitation.
Okay,
And
thank you.
minimal, yeah, patient and inpatient. Yes.
Okay,
Yes, and minimum provide 3 units: emergency department, inpatient, and outpatient.
thank you. They taught you very well, yeah? That is a hospital. So is an institution, as you said, that provides medical treatment, that provides nursing care for people who are sick or emergency, who are injured. And that is what the Oxford Dictionary defines a hospital, yeah? But then WHO has a bigger definition. It says a hospital represents the main concentration of health resources. If we look at the resources of the health system, and the resources here, I mean the money, people, what else is the resource? Equipment, medicines, information. WHO says this is a place where the resources are concentrated. There is nowhere else in the health system which has got more resources than anywhere else than hospital. The Ministry of Health doesn't have as much resources as the hospital has. It doesn't have the equipment. It doesn't have the staff that the hospital has. I do work with WHO, and I visit Geneva, and Normala also went to Geneva once with me. And one of the speakers who from WHO was telling us, he was talking about the resources of WHO. We think WHO is very big, yeah? It's very big, it's very rich. But this man told us the whole budget of the WHO, when compared to one hospital in Geneva, the hospital in Geneva has more budget than the whole of WHO together. So if you consider that level, we can see that hospital is really resource intensive. It has got a lot of professional skills. It has medical equipment that nobody else has got. And it is concerned with the patients to provide them acute. Remember, hospital is meant to provide acute curative care. It doesn't provide chronic care. And we will see how relevant is that. Miller, 1970, he says hospital is an institution which provides beds, yeah, meals, and constant nursing care for its patients while they undergo medical therapy at the hands of professional physicians. So the hospital is there, yeah? It is carrying out these services. It is striving to restore people to their full health. So very proud for people who are working in hospitals, who are managing hospitals. You are having that institution that is really very prestigious. Okay. Now, hospital has specific functions. Tell me, what are the specific functions of the hospital? You mentioned it provides emergency care. What else? What does the hospital do? What are the functions of the hospital? Huh? Let us see somebody else. This class. Hmm? This is worrying. If you don't know what the hospital does, huh? Did you, no, nobody knows. Oh, sorry. Diagnosis, yeah. So it diagnoses, it diagnoses people, it treats people, it provides care, it rehabilitates. Most of the hospitals have physiotherapists. They come and they assess and then they send you home to continue with your. It also says hospitals do teaching. They teach patients, okay? And they train doctors, medical doctors, and other nurses and other healthcare professionals. So those are the traditional functions of the hospital. And we will come back to this to see whether we want the hospital to keep continuing to do this or something different. We also say hospital does research. And research can be clinical research. And clinical research means they follow up treatment protocols and interventions, and they record these, and then they publish these, and then they say this is a research based on this, and they do also nursing research, they do health systems research, and they do educational research. Hospitals also provide health system support by acting as a referral point from the community services, and it also can provide support to the outreach health units, and also hospitals can play a role to supervise primary health care in that catchment area, which some of you have mentioned. You go and visit these health centers and you supervise people, you identify what support they need, what training they need. Hospital also employ people. It is an employment agency, and they employ health professionals, they employ local staff, those who are cleaning, who are repairing, who are fixing when the water breaks down, when electricity. It also is a purchaser of local goods and services. Hospital also buys things from the market. It buys food, it buys, what else does the hospital buy? Medicines, yeah? So it's a purchaser. Now, you will say to me, no, our hospital doesn't employ people. The Ministry of Health employs people, yeah? And they send them to our hospital, and our job is just to make use of this. But with the reforms and the decentralization, hospitals will have a role to employ people. In the UK, there are no government employees. Every hospital employs its own staff, yeah? So, what? 100%, yeah. And it is also a marketplace. It's not only a place it's not only a place to buy things, but it is also a place where people sell things, yeah, around the hospital area. There are surrounding drug stores, yeah, selling drugs. Hospitals also charge fees to patients, and sometimes there are exemptions. It also provides space for enterprises. For example, hospitals will have a cafeteria, and they rent this cafeteria to a private entity. They take rent, yeah? So it provides space for commercial purposes, and it also contracts out services. Because again, with the decentralization and reforms, many hospitals contract out the cleaning of the hospital, the feeding of patients. They don't cook food in the hospital, but they give contract to outside agencies to provide food, to clean. Security, exactly. It can also have a space to rent for parking cars and take money from. So hospital can get a lot of money, yeah? Isn't it? This is what we were discussing. Try to create a car park and charge money for people to park their cars. Create shops around the hospital, rent them so that we can get money for the hospital. So hospital, a lot of things happen. It's not only treating patients, because that is what most of the people think. They only think this is the role of the hospital. Is diagnosis and treatment, is rehabilitation, is education, but it is also research, it is also supporting, and it is also employment agency, and also it has a market opportunities, both for buying and selling. Hospitals also have a societal role. It has a role in the society. And for example, where you have a hospital is a symbol of local community. They take pride of having that type of hospital. And this is why the politicians want to build hospitals. When I was a governor, I have built that hospital. It's given to his name. You know, this is a place where the community is a community asset. It belongs to that community. It's their hospital. Even if somebody built it for them, it is that hospital for that community. It also provides social care, which is non-medical care, and is also a power base. Let's just wait until the adhan is over. He left her. Okay. Now, the hospitals, as we know, are different types. There are government hospitals. These are owned by the public. They are built from public money. They are funded through taxation. They are operated by the Ministry of Health. And they are regulated by the government in terms of how much budget it gets. It controls the revenue of the hospital. Although you might be collecting money from the car park, but the money you cannot use it yourself. You have to put to the Ministry of Finance, yeah, to the treasury. So it controls the revenue, and it also regulates the personnel, the staff who are working in that hospital. It provides the services, which is also influenced by the political imperatives. Thank you. Thank you. There are also other hospitals which are called for-profit hospitals, which have to make profit. They are not just coming out to provide treatment. They want to make profit. That is their motivation. The services they provide are response to the demand from the individuals rather than what the professionals want to provide. They do market analysis. What type of services should we provide in this private hospital? Because in order to make profit, you have to provide the services that are in demand. There are also not-for-profit hospitals like charity hospitals, which you have here. And some of them are based on religious reasons, Islamic host charity or non-Islamic charities. And they operate from donations and acts of goodness. And the staff who work in these charity hospitals are really highly dedicated and conscientious. The services they provide are based on needs, and they try to help the poor more. And their services are determined by demand. Their prices are set to market principles, and the profits go to cause such as poor for funding an institution like school or public health. There are also industrial hospitals, which we know there are many as well. They are part of larger organizations. For example, mining organization, they have got hospitals for their staff. Armed forces or military have hospitals for their staff. Electricity board, they have hospitals for their staff. And the services are to maintain the health status of the workforce who work in those institutions and their dependents. There are also academic hospitals, or they are called teaching hospitals. And these teaching hospitals are to provide educational function in addition to the care and other things, education for doctors, nurses, and other medical health research. The type of services, probably primarily referral, but you can correct me here because the hospitals in the country where I come is mainly work for referral. Nobody can go directly to the hospital to be seen by anyone. Is it true here? Okay. So there is, I know in some countries, I know in China, you can go to a hospital. You don't need to be referred. In fact, they compete with those community health centers. So people go to the hospitals if they are referred to by the primary level or by their doctors. And because they are referral, they are to provide services to deal with acute and life-threatening conditions. And they act also as secondary referral hospitals, which are located in higher levels, province or the capital cities. And then there are tertiary hospitals that offer more complex treatment in regions or for the whole country. So these are the type of primary referral hospitals. Sometimes they are called district hospitals. Then you have got secondary, which are a little bit more sophisticated in terms of the services they provide. They could be located at region or province, or there could be tertiary, which will be more sophisticated, providing sophisticated care and or complex treatment for the region and the country. There are non-acute hospitals. And non-acute hospitals, I mean, those hospitals which do not provide treatment for the what you call, like somebody has appendicitis or emergency and so on. For example, in UK, we have about 2 hospitals in Leeds itself, which act as rehabilitation hospitals. So when the patient has been in acute hospitals, after treatment, while he or she needs to be rehabilitated to be ready to go home, they are transferred to these non-acute hospitals. So they receive some sort of rehabilitation and help them, or they wait there until a suitable place is found. So it's mainly for convalescence, for recovery, and for rehabilitation. And in these non-acute hospitals, it uses very little technology, little medical technology, because you don't need equipment and CT scans and so on. Then the acute hospitals are the ones that deal with emergency and elective conditions. They provide clinical support for diagnostics, pharmacies, and so on. They provide domestic care and hotel functions, food, cleanliness, and so on. And they provide also general support, such as housing, cleaning, and administration, as well as ambulatory care. And they work for 24 hours. So a hospital, as you can see, does not work in isolation. It is part of the health system and is an open system, in fact, and it interacts with its environment in order to secure resources that are necessary for its survival, for its adaptation, and for its growth. These 3 things, in order to survive, hospital needs to get the resources just to keep running. It needs people, it needs money, it needs equipment, it needs logistics, it needs repairs and fixtures and so on. But it also needs additional resources to adapt to the changing demand, as well as to grow. You don't want the hospital to remain the same. You want to add additional functions. You want to add additional units, for example. And this was the definition what WHO has given to the health system, and making hospitals as part of the health system. So health system, according to WHO, says it is all activities which has the function to promote and restore and maintain health. And the hospital is having those functions. So the role of the hospital is to support other healthcare services. It links to primary healthcare. And we heard yesterday about the Alma Ata Primary Healthcare Declaration. And district hospitals, accordingly, it has crucial role to receive referrals and technical support, as well as to support rather than to duplicate. This is another important thing. When there are different hospitals in the district, 1, 2, 3 hospitals, make sure that they don't duplicate the same thing. They support each other, yeah? For example, I will use the example of where I come from. In Leeds, we have 3 big hospitals, really big. And these 2 of them are actually bigger. And then we have satellite district hospitals. Now, these 2 big hospitals, which are located a little bit miles apart, 3-4 miles apart, In the beginning, when I went there, they were all doing the same thing. The St. James Hospital and also the Leeds General Infirmary. After a while now, they have made this hospital, each of them to be doing several certain services, not duplicating. For example, all neurology is left for one hospital. All what they call oncology is left to one hospital. All gastroenterology is left to one hospital. So the two hospitals are not dealing with gastroenterology, with neurology, with oncology. Yeah. So they support each other. They both have emergency, accident and emergency. So the ambulance, when they pick the patient from home, they know where to take him. If this is a heart attack, they know where to take him because they don't want to waste time to take them to the wrong hospital. If it is a stroke, they know where to take him. They take to the hospital which is providing neurology. Okay, so hospitals supporting each other in that way rather than duplicating. We wait for the adhan, yeah? Thank you. Okay. Okay. So what we said is the hospitals need to support each other rather than duplication. What do you think are the problems of duplication? If okay,
Okay, thank you. We already discussed about support but not duplicate because in Indonesia, it seems like all hospital build duplication. all the hospitals should have like a CT scan, MRI, and etc. The problem for the hospital that the hospital needs a lot of budget to meet the requirement. But if like you say that one hospital oncologist, one hospital what else like other internists, how the people or the patient if they need to consultation. For example, they have a diabetic, but she needs cardiovascular and she has to go to other hospital. It's will be difficult for patient to move from other hospital to other hospital. So what is your opinion about it?
Okay. What I was saying is the hospital, we have two hospitals, and these two hospitals, they try to divide the functions. One hospital has got oncology unit, and the oncology unit has all the investigations for the oncology and so on, including operation theaters and etc. It also has gastroenterology, so or everything to do with the operations of the abdomen, liver transplantations, and so on, including the necessary investigations and so on. The other hospital, for example, is not very far from each other. They're about 2 to 3 kilometers away from each other. 2 to 3 kilometers mainly. So it does all in fact, very modern. It does all the neurology and cardiology and all those sort of things. Then there is another hospital which deals with the maternity, so the deliveries, etc. The only hospital, the only service that is duplicated is the delivery, because the two hospitals have got, and the reason is the catchment areas, because sometimes a woman in labor cannot come to the other hospital, they go to the nearest hospital. Now, what you said is, for example, the question is, in case a patient needs to be seen by a diabetic specialist or by a cardiology specialist, do they have to go to that place? Yes, they have to, because all the outpatient clinics are located in that hospital. But most of the follow-ups and checkups are carried out by the primary care health facility. So the general practitioner does a lot of that with nurses. I was telling her when she was saying, in this country, people tend to be asking more specialists. More specialists, more specialists, more specialists. And what we think is you don't need more specialists and more specialists. You need actually reorganizing your services. You need to think of multi-skilling or multitask skills. For example, these days, a lot of cardiovascular diseases, if they are not emergency, heart problems and so on, they are dealt very well with cardiac nurse than a cardiologist. Yeah, a nurse who is trained. I was explaining that I happened to be seen by this nurse once, and I was much happier. In fact, I told this gentleman, I said, I am much happier because the way you have spoken to me, the way you have explained the condition to me, the time you have given to me, I would not have been getting from the doctor, who is very busy usually. So, so the duplication is a problem, because you waste your money. If you are doing the same thing in every hospital will need to have CT scan, MRIs, and so on. But here you don't. You know, you organize. They are all in one place, and they work 24 hours, by the way. So for example, for inpatient, even they can take the patient for MRI at 1 o'clock, 2 o'clock, 3 o'clock. Yeah, it's their function. And then for patients who are coming on outpatient basis, they do it during the daytime, during evening times, and so on. So the health service delivery, I think avoiding duplication is very useful. Another important thing I wanted to mention is this idea about dominant hospital and other health services. You know, some hospitals, they prefer to be the dominant hospital. Because they want to monopolize the skills of the staff, that they have everybody there in their hospital. They can get the large share of the budget because it is the most dominant hospital. They can bypass the primary level facilities. They can admit patients without going through the referral processes. And these are the type of hospitals that we find in most of the low and middle income countries. A big, dominant, important hospital. And they intend to undermine primary healthcare facilities. The example you mentioned about China, China have got these hospitals which are competing with the primary care facility because they provide the same, they are duplicating. So patients would prefer to go to the hospital rather than coming to the primary care facility. And then there is something called the hub hospital. The hub hospital is a hospital in the center which is catering other sub-hospitals. There might be surrounding hospitals, and they act as the center hub for integrated district services. They involve with planning and administering and funding of community health services. They might not be involved in the provision of service. And the example of this hospital is, for example, administering community clinics. It has a lot of clinics surrounding these hospitals. Then there is something which is called a comprehensive hospital. And this is found in many developing countries, and it provides all levels of healthcare, preventive and curative. It provides service outside of hospital, and this is an example of a district hospital also offering immunizations. Separatist hospital is another example of a hospital which is separate from the general practice surrounding that hospital. These are most common in high-income countries, and they provide acute care. They are highly specialized, and the principle of functioning is that healthcare is expensive and must be used cost-effectively, and they are controlled by community-based health services who are the general practitioners or the gatekeepers. These type of hospitals are not common in low to middle income countries. As you can see, you have got a GP facilities, and the hospitals you are used as a referral to provide acute care, and because they feel having more hospitals, they are going to be more expensive. Now, if we look at some of the environmental influences of the type of hospital that you need to have so that you don't duplicate. One is think about the demographic changes, the population that you are serving. Are you serving more children? Are you serving women? Are you serving the elderly? Are you serving the young? Think about the population migration, who move from one hospital to the other hospital, the epidemiological transitions regarding morbidity and mortality, increased life expectancies and economic pressures, which can come from the needs and demands of individual patients who are asking for more and better and quality. The length of stay can influence the hospital, the functions of the hospital. Income generation, hospitals that have fewer external donors, and there are not many donors who fund hospitals, and also the population ability to pay. They can also influence the type of hospital you want to put. The politics and the donor influences, trying to separate from civil servants or civil service, making hospital accountable to recruit, to promote, to fire their own staff rather than using the civil servants. Preventive and elective procedures rather than emergency ones regarding allocation of money, and the reforms such as decentralization or autonomous hospitals. So these are the environmental influences of a hospital and the contracts they provide. Still, other influences, for example, the policy developments, are critical as well. The trends, hospital functions are changing, so the trends in the environment, for example, what we find these days is that surgeries are minimally invasive. A lot of surgeries these days are done using keyhole surgeries, for example. So not as invasive as they were before, opening the abdomen to remove the gallbladder. Or even more major surgeries are less invasive. And because they are less invasive, usually they are done on a day basis. A patient is admitted in the morning, gets the surgery done, and is discharged in the afternoon or in the evening. Another influences are the new pharmaceuticals, the new medications is also reducing the need for more hospitalization. A lot of people are getting treated outside the hospitals because a lot of medications are available. There is also a change. A lot of treatments that used to be provided by tertiary hospitals can be provided now at lower level. As mentioned, the cardiac nurse who can be based in a primary hospital, providing that care instead of a cardiac specialist sitting in a tertiary hospital. And then decentralized management as well, which is making the contractual processes of staff more localized. And then the staffing as well is emphasizing the competence rather than credentials. And since COVID-19, telemedicine is becoming very popular. Rather than going to see the doctor physically, most of the consultations are done over the telephone. So this little diagram, what I'm trying to show is the hospital functions, which are set here in the middle: housekeeping, inpatient, purchasing, diagnosis, personnel, and also providing outpatient services. We need to think of the inputs and then the outputs as the result of those inputs. And then we have several types of hospitals. We said we have government hospitals, we have private hospitals, we have clinics, we have health centers. So these can be looked in a more integrated way rather than separately. And then we have seen the environment, the factors that influence the type of hospital, the type of health facility that you need to have. And think about environmentally the natural disasters. If the country is, or if the region, if the district is located in an area which is prone to natural disasters, flooding, earthquakes, tsunami, and so on, you need to consider this when you are constructing or planning for your hospital. Think about the relationship between Ministry of Health and Ministry of Education, because doctors, nurses, etc., they are produced by universities. The universities are often run by the ministries of education. And then the users of these professionals is the Ministry of Health. So that discussion between Ministry of Health in terms of the type, the quality, the quantity, the specialisms that universities have to produce need to be done in consultation with the Ministry of Health. The financial policy is crucial here as well. And the health policy that governs everything that we are talking about, the political stability of the country. There are countries that are in a shaky position, and there are countries that are politically stable. Every now and then elections are done, governments are changed peacefully. There are countries that are going through turmoil. So the health sector reform that was introduced in the 90s is really challenging to the healthcare provision. And they are providing alternatives to healthcare. These are worldwide trends. It's happening all over the world. And the examples of the reforms, which I'm sure Indonesia is also going through, is decentralization from the center to the regions or provinces, and provinces to the districts. A lot of hospitals are getting autonomy, and I hope the autonomy is real autonomy. Hospitals are allowed to charge fees, so the idea of user fees or third-party payment, insurance payment, contracting out services rather than providing everything by the hospitals, is to contract other agencies for certain services like cleaning, security, what you call meals or food. And the pressure from the market to improve management and to achieve efficiency in the resources utilization. For example, with decentralization of hospitals, the idea is if hospitals are given autonomy, are decentralized, there will be improvement and effectiveness in the management of the hospital. And these decentralizations of hospitals is meant to overcome the disadvantage of the central management of the health system, and is to make the needs of the local population heard, or the hospitals become, or the health system becomes more responsive to the local needs, and to improve also the service delivery. However, this idea of decentralization is complex and is also depending on the different context, even in the same country. Even in your country, you have got the West, you have got the East, you have got the center, you have got, even with your own who are lazy, whatever, you have got north, south, west, and so on. They are all different. And this decentralization has to respond to the different contexts. It is about transferring the authority from the center to the local levels, And this transfer of authority has to include money, political, administrative, and decision-making responsibility, as well as the use of resources, including autonomous hospitals. Hospital autonomy, again, is something very relevant for you because hospitals have in the past experienced problems with the hierarchical bureaucracy. You have to get approval from the top because they lack control over day-to-day operations, because they were inefficient resources and financial management, and they were non-responsive to the needs of the users, and they lack performance-based incentives. So the solution in regard to autonomy of the hospital was to move from centralized management of hospitals by the Ministry of Health to the decentralized decision-making and introduction of market-type reforms. So hospital autonomy, therefore, is about decentralization of decision-making, is about adapting some of the features of the private sector to run those hospitals. So what we are doing here in the autonomy of the hospital autonomy is trying to focus the decision-making ability and the areas that these decisions have to be made. So the idea is changing from the traditional way of managing hospitals to more autonomous hospitals. That changes the role of the Ministry of Health. That makes the hospital more independent. That makes the resources sufficiently available, and the autonomy is often managed by the board, and the qualifications of the chief executive officer of the hospitals is important in that case. Now, the implications for these reforms and autonomy to hospital is it has to do with generation of money, third-party financing, and skills for contracting and managing those contracts, and may be able to deal with the competitions in a better way. That is the context of which we are all in, and Indonesia is part of this game, maybe in a different way. Decentralization is part of the political process here, is commitment of the government. Powers and authority and decision-making are shifting or have been shifted from the center to the periphery. The movement of hospital autonomy is ongoing. Many hospitals are more autonomous. The management is more or less based on that. I don't know to what extent this autonomy is full functional or is not, because it also allows hospitals to generate their own resources, to employ their own staff, to sack their own staff if they feel so, and to develop their skills of their staff. Now, the changing roles of hospitals first of all, why do hospitals exist? We said hospitals exist because they provide patient care, which include diagnosis, treatment, and rehabilitation. It also provides teaching, it provides research, and as you can see here, this is all not what we so if existed because so far, but we don't want them to do those things. Are you following? I can see half of my class is asleep. Shall we stop and make maybe people stand up and walk a little bit? Yes. Just get up and maybe walk a little bit. It's long time sitting.
Ya, udah kelihatan setengah peserta ngantuk. Okay, we can
Okay.
continue.
Okay, that's good. So I'm sorry, I don't think it's good for people to sit like this for 5 hours. So the question was, if we are thinking of changing the role of the hospital, we need to first of all say, why do hospitals exist in the first place? And we said hospital exists because of these reasons. But now we are saying, no, the hospital don't exist because of these reasons. So what do you think? Why do they exist? Can you ask them in Indonesia, why do they think the hospitals exist?
Kira-kira kenapa rumah sakit masih eksis? Bisa dalam bahasa saja juga menjawabnya. Kenapa? Innovation? Regulation? Yes, sir. Tidak terdengar, boleh sedikit mic.
Thank you, Dr. Mayo. I think the question about why do hospital exist, this is about how the government responsible to the people, to the community to provide facilitation in kind of health services. Besides that, hospital is needed by the people, not only for disease, not on, but in terms of how to provide care, so that the people know how to find a place that suitable for them. That's it.
Thank you. Thank you. Any other suggestions? I think that's a good contribution. Huh?
People sick.
Because people are sick.
Yeah.
So people are sick. The hospital exists in order to diagnose, to treat, and to rehabilitate. Yeah, and we are saying no. We are putting We are saying no, we don't think this is the reason why hospitals
Government
exist.
regulation.
Huh?
A government regulation as a
Okay.
public services.
Okay. Anyway, hospital important, but what I want is us to think again. If we want to change the role of the hospital, the background I have given so far started with describing this role. Then we talked about what is going on around the world in terms of the changes, the environmental changes, the reforms, the autonomy, the decentralization. Do all these changes make a difference of why the hospital exists, therefore? So I put this back because we talked about these functions of the hospital, and I said, let us think what else. Why do we think hospitals exist? And I'm proposing this, for example, hospital exists for the benefit of doctors and other health professionals. Yeah. So a lot of the time, most of the hospitals, they benefit the doctors more. All activities in the hospital are organized around doctors and medical staff. They are organized around diseases. They are using the medical model. So this is like, actually, hospitals are not fit for purpose. And the title of this presentation is about how can we make the hospital more patient-centered. This model that we have here is not centered around the needs of the patient. Yeah. In fact, it is centered around to benefit the doctors. It is centered around organizing the services around diseases, medicine, surgery, ophthalmology, orthopedics, etc. It is also a medical model. It doesn't go beyond the medical. It's fixing when somebody is unwell. So the medical model is very authoritarian because the doctors see themselves to be experts. They are authoritarian in the relation to the patient. They are dominant healthcare professionals. Everybody go and manage a hospital. It's the most difficult thing to manage because managing doctors is not easy. They believe that they are sacred professionals. Nobody knows better than them. Their word has to be taken. You know, the hospitals in the UK who manages the chief executive officers are some people who used to be managers of supermarkets. Yeah. People who are managers of banks. So, here it should be medical. And it was a challenge for these managers who are coming from economics background, management background, business background, to have influence on what the doctors should do. I know a lot of big hospitals are managed by the most senior healthcare professionals, the super specialists. The senior neurosurgeon becomes the medical superintendent of a hospital. And hospital management. So when you have that type of person managing, then everything will be around the benefit of the medical professional. So they dominate. And the patients are expected to comply with the advice that is given to them. go and do this, go and do that, take this tablet 3 times a day, do exercises every morning for 15 minutes, go for a walk, eat this and don't eat that. They don't even know whether a patient can afford to eat that and not this, or to have time to go and walk for 15 minutes every day, because they don't understand what else these individuals have to carry on their shoulders. So if these are the two dichotomies, what is then the integrated people-centered health service? And this is a new approach to care. It revolves around the fact that not the doctor, but the patient. It's sometimes referred as patient-centered care, and it adapts the perspective of the patients and not the doctors. And it sees patients as participants, not as patients, sick people. It responds to the needs of the patients and their preferences. And it sees patients and makes patients to participate in their own care. And it is organized around the health needs and expectations of the patient. How is this done? The way it is done is, for example, I have spent quite a lot of time with doctors as a carer and so on. When you go, they ask you, what do you expect to get out of this? What are your expectations? What are your objectives? If you have back pain and you go to see a physiotherapist, usually a physiotherapist in the old model will give you massage and will ask you to lift your hand up and this down and so on. With this approach, the physiotherapist will say, what do you want to achieve from your physiotherapy experience? So you set the objectives. I want to be able to stand. I want to be able to lift something. And then based on what you want to achieve, then you plan the care together. In order to achieve this, you will have to do exercise every morning for 15 minutes. Not I come here and I will do exercise for you. Not come and I will massage you. No. Is you do A, B, C, D, which you agreed with the physiotherapist, so that you can achieve what you have both agreed. So this care is organized around the expectations of the patient. And the patients participate in their own care. Yesterday, one of the problems I mentioned about the good health care in the UK, the NHS, I said patients are not involved in their health care. So patients' participation, it is happening slowly, but it could be done better. So the core elements of this people-centered health service is education, 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 educating these patients who are not called patients, but participants. The Americans call them clients because they pay for their health care. Yeah? And sharing the knowledge about what their illness is about, what could have caused this illness, what could be done in order to make them feel better. The second is involving them and their families and friends in the plans and the care that is going to be provided, and making this as a collaborative approach to team management, patients, relatives, healthcare staff, they all sit together and discuss about the care plan of these participants. The other thing is, this patient-centered approach is making health professionals to be very sensitive to non-medical and spiritual dimensions of care. And what is meant here is because these individual patients, they also have their beliefs. They have religion. They have faith in God. They have heard a lot of things that when the old model of a doctor dominating and considering himself as an expert, saying, no, those are rubbish, what you are talking about. Here, it's saying these health professionals have to be sensitive and accept and respect the non-medical things that are not based on science or medical belief systems, but by, for example, if the patient says, you know, I need some to have few religious people to come and pray for me while I am in a hospital or before I go for a surgery. Accept it. These water, Zamzam, which came from Makkah, I need to drink before I have this thing. Accept it. So showing that sensitivity is part of the patient-centered healthcare. Especially with conditions of mental illnesses, because people have different belief system of what causes mental illness. And we, from medical background, believe they are caused by different things. But if somebody says, yeah, I need a religious person to pray for me, or their relatives say the same, there is no harm to it. And respect for patients' needs and preferences. And then the most important thing is the free flow and accessibility of information. So whenever patient needs to know more, please be open to explain, to give the information they want. So these are the core elements of what is considered as integrated patient-centered health services or people-centered health services. Now, for everything that is to be done, it has got drivers, people who can drive this new approach to success, and there are obstacles or hinders of the idea. One of the drivers of why the health system or hospital care is considering this to be important is because we are shifting to non-communicable diseases. And I said earlier, non-communicable diseases are lifelong chronic diseases which do not have a cure. And if these conditions are, if people are going to live with these conditions for the rest of their lives, then they need to be consulted, informed, given enough advice, and any plan for their treatment to be agreed together, because some of the treatment plans have to be done regularly. If you want for the person to bring his BMI down, then this person needs to be part of that game and accept and do whatever is appropriate for him. And what he can do, sometimes just saying people diet, run, exercise might not be suitable for everyone. So sitting and talking together what is doable and feasible is always more successful than telling people. It is also driven by the old concept of fragmented patient care. Fragmented means care that is all over, not provided as a unit in one place. And it is driven by the fact that patients were unable to make appropriate decisions about their own health. People smoking, developing complications because of the smoke, they are not able to make the decision to quit smoke. Now they develop this chronic disease which they have to live with. Then patients were unable to exercise control over their decisions about their health care. These are the drivers, the reasons why it became important to reconsider the way we look after our patients. The benefits of this approach of people-centered health service is it allows decisions to be shared with professionals. Whatever is going to be done, it is shared. Individuals concerned are involved in planning their care. It increases patient engagement. It increases the ability to self-manage and control rather than waiting to be cared by a professional doctor or a nurse, but you make people more independent to be able to care for themselves and to manage their conditions and to control their conditions. It also increases patient satisfaction with the type of care that is provided or the care they are getting, and also the quality of life. So you see, these people, integrated, people-centered, it came out of the need and of the limitations of the current model of hospital care. And it's driven by all the factors that we have mentioned, the dominance of non-communicable diseases. And most of the people requiring long-term care. And the benefits is that it allows people to share information with the professionals. It gives them more autonomy and responsibility to look after themselves. It increases engagement with their care. It increases satisfaction. It improves their quality of life. It also improves disease management of patients with chronic conditions. And this approach is seen to have less medical errors. You know, medical errors are causing quite devastating effects on a number of people. And there are a lot of litigations in most of the European countries because of the medical errors. If people are taking the responsibility about looking after themselves, then those medication errors are reduced. And we started this morning and say resources are limited, few. This approach increases efficiency. It will not require because my friend there mentioned the patient who has got headache needs to have MRI or CT scan. If patients have got explanations and information about their condition, they might not require CT scan, yeah? Because they already know what condition they are suffering from. It reduces the referrals, so you know what the condition is. You are looking after yourself. You are taking part of. You will not keep asking for specialists and specialists and specialists, because you realize that your condition, how many specialists you are going to see is not going to make any change, because the person is having chronic condition. And it reduces hospital attendance rates so that there will be beds available to deal with the acute cases. And it will save money. Yeah. So we need now to introduce this. It has got so many advantages and benefits. How do we go about introducing? Can you have any ideas how to introduce these integrated patient or people-centered health service in Indonesia, in Makassar?
Kira-kira gimana memperkenalkan konsep patient people center health services ini di Makassar? Ya, silakan Dr. Indah.
Thank you. We know about interprofessional collaboration. I think the same principle with integrated people-centered health services. Yeah, patient-centered care, and we know interprofessional collaboration, but it seems still difficult to implement it because there every professional, every specialist has their own autonomy. Then now we start to introduce and develop interprofessional education. So we start to educate the doctor to get to experience interprofessional education. So when they become a doctor, become a specialist, they more terbiasa, will be get used to be a collaboration with other professional. Now in our hospital, Hasanuddin University, our mission how to develop interprofessional education. So we will produce specialists that will get used to be interprofessional interprofessional collaboration. I think that. Thank you.
So training our healthcare professionals.
Yeah.
To
yeah. Yeah.
Okay.
Because now we ask the doctor to do interprofessional collaboration, but when they educated, they did not experience about how to collaborate with other profession.
Yeah. Yes. I knew a lady who was having chronic liver disease. And always she will be waiting for the next appointment with the consultant. And in between, she has nothing to do. So until she sees the consultant, and then she will say, I am very surprised. You know, I go to see this consultant in a hospital. This is a liver specialist. This specialist, she called the big doctor. This big doctor doesn't look like a doctor. He doesn't have the white gown. He's just like you or like me. Don't even a tie. He doesn't have. He just sits like somebody sitting in the office. No, nothing, stethoscope, and he just listens to me and asks, how are you? And listens to me and then tells me, okay, I will write to your GP. And she leaves and she waits for another 6 months to see this big doctor again. What was missing is this approach is to explain to this patient, to say, look, you have got this condition. We don't have a cure for it. You need maybe to, what do you think you can do? Control your diet, walk a little bit every day. So make them part of the planning process of her care. And if you have any problem, contact your doctor or contact me or whatever, rather than every time waiting to be seen by these specialists, super specialists, who does nothing to him or to her. But these doctors, as you say, they want some patients to come and see them. Yeah? It's the monopoly, is the importance they see to be important. So preparing these people right from the beginning in their schooling, in their professional education, to be different from what their predecessors are, is very important. So that is an approach, in fact, to say we need, but not only waiting for the new generation of doctors, but we need also to retrain the current ones. Regular CPDs, continuous professional development, and helping them to change, making it a protocol requirement that this is how we should be looking after. We should not treat these people as patients. They are people. They are our clients. Yeah, we exist because of them. We get salary because of them. Like I say to my students, I have to do everything you want me to do because I get my salary because of you. You pay my salary through the fees that the university is charging. And therefore, let us do it together. Let us work together. How can I make you a better healthcare manager or public health expert in the future? What do you want to do with the knowledge that you acquire from here? So the introducing this is the first thing is to reorient the medical care model. The model that has been in place, we need to reorient it to this new model, changing it. And reorienting is retraining people, changing the way the services are provided, empowering and engaging people, making this as a requirement. Empowering people is giving the power to the people, not to the doctors, to decide about what they want. If a patient says, look, doctor, I am really tired of I want to stop this treatment. I don't want this treatment. Will you stop? Huh? If the patient is having one of these chronic conditions and tired, means just lying in bed for 3 years, I say, look, I don't want to continue. Think about it. Strengthening governance and accountability. That is the way we are open, transparent to people we work with, and take responsibility and allow people to take responsibility about their care. Another way is to coordinate the services that we are providing, coordinating with all the professionals involved. The doctors, the nurses, the home visitors, the rehabilitation, the social services, the individual patients, their families, all of them. And then creating an enabling environment. You see a lot of things, all these good things we talk about, they don't happen because the environment is not conducive, is not enabling, is not supportive. I want to do this, we talk about this, we want to make a hospital like this, but I'm not getting the resources. I am not getting the support. I am getting a lot of opposition. And to deal with all this, there is no one solution that fits all. It needs to be considered differently. I always find these, what you call stakeholder analysis, very useful. Look at who are your stakeholders for this to happen. Stakeholders are people who either are going to benefit or who are going to lose from the changes. Don't only think of the people who will be benefiting, but also think of the people who will be losing. Because the losers will be your enemies. They will be the ones who will try to make it a failure and to say, look, they brought these changes, We told them that it is not going to work. Now it has not worked. So we need to involve those who we think are losers, are going to lose, not losers, who are going to lose the influence, the monopoly, the power they had. And that is what makes management and planning political. It's not technical. We all know you do this, you do that. But the political element is important to find out what is the power and the role of all your stakeholders. So if you know the ones that are opposing you and you know their power, if they have no power, you cannot worry about. But if you think they have power, then you try to engage them as well, to accept, at least to be neutral, at least to support you, at least to give you the chance. The process is very, very slow and long. We fail because we want to, we make a decision, the governor makes a decision yesterday, and we want everything to change today. And after 1 month, nothing changed. We go back to where we came from. So creating this enabling environment is really important. And in conclusion of this session, I want to emphasize and mention that the patient-centered care can produce healthcare that revolves around the patient. It can increase patients' participation in their own healthcare. It can reduce fragmentation in healthcare. It can lead to better health outcomes and better quality of care. And it can increase patient satisfaction, and it will save money. I want you to take those messages and start thinking of these patient-centered. Okay, and you as people who have got the opportunity to study hospital management, please take this and learn more about it. And I have provided a list of useful references which you can look back and give you more information. And I hope we addressed the objectives of the session that we said we will address. Thank you.
Alhamdulillah, thank you very much, Dr. Maya. So, ladies and gentlemen, this is the end of the session of our guest lecture. The second topic about the changing roles of the hospitals. Dr. Maya already explained about the context of the hospital and also the environmental changes like political and donor influence, economic pressures, health policy development, strength of hospitals, and also the implication for the hospitals. And the end of some slides, also the changing roles of the hospital. We have to realize why do hospitals exist, and consider changing the roles becomes an integrated people-centered health services. Thank you, Dr. Maya. Today we have a very, very good knowledge about the rethinking the hospital and also changing the role of the hospital. So please give applause to Dr. Maya. We have a taking picture
I don't
session.
get applauses in Leeds, so I'm very happy.
Oh, there is no applause in Leeds.
Excuse me.
Yeah.
Can I ask one thing to Dr. Mayo?
Yeah, please.
Can I?
Yes, please.
Okay, thank you. So, can you explain briefly, based on your experience in UK, because we know NHS system is the best in the world, even better than United States. I want you to explain in UK, particularly in Leeds, because you have mentioned about 3 big hospitals in Leeds, like Leeds General Infirmary, St. James Hospital, and Chapel Allerton Hospital. I read that 3 big hospitals, one is government hospital, one is university hospital, one is like charity hospital. how far the involvement of local government to control these three hospitals in terms of how hospital running well, related to the medical doctor, related to the nurse, related to providing equipment.
Okay.
Because in this country is quite different with that.
Thank you.
That's the second. The second one about integrated people care health service. Actually, in Indonesian experience, we have like that. We call it integrated medical doctor clinics, but small area. But this clinic running with profit oriented. This is a problem because in our context in community, we have two segment community. One is community or people with ability to pay, and the second one about the people willingness to pay. That's the problem. How can people want to visit this place if they in the willingness to pay condition? And in the UK situation, like the biggest hospital in the UK, like Manchester Royal Infirmary, that has 17 beds. This is strengthening the hospital if the concept of integrated people health patient center exists in the UK. Thank you very much.
Thank you. Yeah, thank you. These are some of these are contribution from what you already know. Yesterday we spent about 3 hours talking about the NHS and comparing it with the US system and how the NHS is run. For example, in Leeds we have 2 major hospitals, which both of them are university. I mean, they are not university, but they are also teaching hospitals. They don't belong to the university. They are used to teach medical doctors, nurses, and so on. And some of the professors some of the clinicians in these hospitals, the specialists from those hospitals, they are also university professors and university lecturers. And the arrangement is, because these are very expensive people, the arrangement is that if they are working for the NHS, the university pays half of their salary and the NHS pays the remaining half of their salary. So this is the arrangement between university and the hospital. The issue is there is no, the local government or the local councils have no role in these 2 hospitals. There is a clear distinction between medical care and social care. So these hospitals deal with acute cases, patients, and then the local government deals with the prevention, public health, and long-term home care for the individual patients. So for example, UK, England, which is the body responsible for health promotion and disease control and so on, they work very closely with the local government. Yeah? And the same thing, people who are teaching in the university and also working in the preventive services and with the city council, again, we share salary, half is paid by the city council and half is paid by the university. So there is that clear distinction. And then people who require long-term care, for example, disabled, the elderly, who are given care from their homes, then the city council also is responsible to a large extent. And this is mean tested. For example, if somebody is needing home care, they check how much saving or how much income this person gets from his pension, from if he has got any assets, houses where he is collecting rent and so on. And if he has savings of, say, over £15,000, for example, they are required to pay part of their care at home, and the remaining is contributed by the city council. If people have less income, less savings, or no savings, then 100% of their home care is covered by the Leeds City Council. So that those are the arrangements that take place. Now, this new concept of people-centered healthcare is really taking shape quite well in the UK and in Leeds in particular. For example, there is patient doctors task forces or committees in every catchment area. You know, the GP has got this board consisting of users of the services and the health professionals, and they meet once every 3 months. They go through the feedback that the patients are giving. They plan what is needed to be done, and then these consulting the patients, making patients part of the informing them and making them part of their care plans. This is all ongoing, especially with people who are having long-term conditions. With people who are, you know, acute cases, then that is a different story. So that is what I just wanted to add. The other one you mentioned is about St. Mary's Hospital. Is that right? What was the issue you wanted to? Was it a question or just a contribution to the discussion?
I think it's related with the future, with development of information technology.
Yes.
I think for that time, many people do not visit hospital again because they can use like advice by telemedicine, by telehealth, by electronic health, something like that.
Okay. Yes. Yeah. Since COVID-19, one of the progress that is made, I consider this really a progress, because during the lockdown, visiting doctors, even the GPs, was stopped. It was only happening when it is really essential. So a lot of consultations up to now, most of the consultations are taking place over the phone. So it's the phone consultations, sometimes video consultation, you know, using Teams or whatever. And with the specialist appointments, which more with people who have got chronic conditions or follow-up, it's all happening a lot of the time through telephones. So I was feeling very uncomfortable in the beginning with this, but I now felt it really improved access to information and getting answers to the questions, and it is also more efficient and a lot of cost saving. Yeah. For example, just taking my role as a university teacher, I used to have an office. I used to pay rent to that office. I used to pay electricity to that office. I had a telephone. I had my desktop. Now I don't have. And it is saving all the money that I was paying for that. So I work from home most of the time, and I only go to the university if I have to go. And it is saving money to the university too. So, I'm really finding, and I feel comfortable. Instead of waking up at 6, getting dressed and run, I can wake up at 8 and just maybe put my shirt and sit and work. Yeah, and I can do more than I was doing before. So it has also changed the way healthcare is provided. These telephone consultation, video consultation, and so on. I just want to mention, you hinted about there are people who are able to pay and willing to pay. One of the problems with the NHS is the waiting list is long. So for people who are on elective emergency cases, they can wait for months and months and months to be seen by a consultant or a specialist. And it has its own drawbacks. Sometimes your condition can get worse, although you are told if you feel serious, please contact the emergency. But those who are willing and able to pay, there are also private hospitals. Yeah. So they can seek treatment from those private institutions. In London, there are quite excellent private hospitals, so provide private. People come from all over the world. Even in Leeds, we have the Leeds Hospital, the Nuffield Hospital, which is not part of us, but we use this, we share the same name. It does provide private care for people who are able and willing. For those who are not able, willingness has to come after the ability. They are getting their usual treatment through the NHS. And yesterday I mentioned, yes, it is a good model, but it is a lot of people are not satisfied because of the underfunding now, they say, because the cost is increasing. Again, the same story of the changing demography, the elderly people, comorbidities, people having more than one medical condition, people requiring long-term care. So it is affecting for example, people staying longer in the hospitals because there are no community services enough to discharge quickly. That is affecting emergency conditions when a patient is brought in by the ambulance. There are reports that they are staying in the ambulance for 3-4 hours because there is no bed available. So it is not the most perfect health system now, but it's still working well. Thank you.
I think that's all for the session. Only one question. We have only 1:13. Okay, thank you very much, Dr. Maya Omar. Have a speech for the end of the session from Mr. Shahrir. No? Okay. Okay. So maybe just ada ya? Okay. Yeah. So we have a token of appreciation for today's guest lecture. So please, Prof. Alimin, to give the token of appreciation to Dr. Maya Omar.
Just before we leave here, can I just thank you and from the depth of my heart, wish you all the best in your studies. I hope you will be successful, and you will make the difference in the way hospitals are run and are managed now and in the future. Thank you.
We also can take a picture together with the all lecturers and students from Hospital Management Study Program, please.
Satu, dua, tiga. Satu, dua, tiga.
Study in